Hello and welcome to Digest This, where we focus on day-to-day clinical issues in gastroenterology. I'm Elaine Robertson, a gastro trainee in the west of Scotland. Today we're discussing therapeutic drug monitoring in IBD. And I'm delighted to welcome Dr. Graham Naismith, a consultant gastroenterologist at the Royal Alexandra Hospital in Paisley, with an interest in IBD, but also with an interest in therapeutic drug monitoring. Welcome, Dr. Naismith, and thank you for taking the time to join us today. Now, I know that you incorporate therapeutic drug monitoring into your routine practice, really, for patients with IBD. Why do you think it's so important?
Well, thank you for inviting me, Elaine. We find therapeutic drug monitoring complements our service well. We think we need all the help we can get. The more information, the better. There's debate in the IBD community about its role and where we should place it, and I suppose that's what we're discussing today. But I think the patients themselves seem to understand the concept and understand that we are actually actively monitoring their therapy, and they seem to have a good understanding that even about antibodies and the more niche aspects of drug monitoring can be picked up, and it helps them have confidence in our service.
Okay, let's start then with the thiopurines, so azathioprine and mercaptopurine. They're really commonly used drugs in IBD. And when we think about monitoring, we're really talking about metabolite monitoring, aren't we? So I guess we have to have a working knowledge of azathioprine metabolism. Can you talk us through it?
Well, azathioprine we're still commonly using as our first option for thiopurines, and it is a prodrug. So that's immediately our 88% move towards 6-mercaptopurine, which is, of course, our alternative. The dirty part of that metabolism is metabolites are released with GI side effects, and should GI side effects occur, we will move directly to 6-mercaptopurine. But the metabolism itself has many different stages, as you will see in the slide, which we'll show just now. And our toxic metabolites can be altered with us making some clever medical moves, which we'll explain later.
And what do the different metabolites mean?
So we know that the MMP, methylmercaptopurine metabolites, are dangerous to the liver. Certain people in the population will create too many of these metabolites, and we will pick these up through liver function tests. But in the age of precision medicine, we'd like to be able to identify people who are more likely or less likely to develop toxic metabolites, or people who are able to less well metabolize the drug. We, as standard in most centres these days, check for thiopurine methyltransferase enzymes. Genetic polymorphisms are common in the general population, and 1 in 300 will have no activity at all, and therefore have a great risk of having toxic levels of thiopurines.
And the therapeutic metabolite is 6-TGN?
Is 6-TGN, and we're now able to monitor that in our own practice and devise approaches to improve people's therapeutic levels.
So when should we check drug metabolites?
Well, there's two different ways to do this. We can check proactively or reactively. And reactively means checking when there's a problem. And since we've had these available, most centres will check reactively. When we have limited availability of these tests, we're encouraged to check reactively because there will be fewer tests checked. And it makes sense to do things in that way because many patients, up to 90% who get through the first few weeks on thiopurine, may have no further problems. But if they do develop problems, as they can do at any time, it's a reasonable time to check a level.
Now, the alternative would be to do it proactively. What do you mean by that?
So checking proactively will be effectively screening for problems, so checking before the problems arise. There are some difficulties in checking things proactively, one of which is we end up sending more tests. And these test costs are around £27, depending on which centre you're in. And I think we have to be responsible about how we check these tests. The other issue is it may take longer for someone to get to an active therapeutic dose if we're being more cautious and checking regularly, and therefore, theoretically, the patient may be at more risk by us taking our time over things.
So are you saying then you do a weight-based approach and only check if there's a clinical problem, or do you have a weight-based strategy and then routinely check a level?
So we will do a weight-based approach, so approximately 2 milligrams per kilogram for azathioprine and 1 milligram per kilogram for 6-mercaptopurine. And we'll try to work up to therapeutic levels from low doses to normal levels within 4 weeks, and then continue weekly monitoring for another 2 weeks. Thereafter, if there are any problems with symptoms or abnormal blood tests, we would then try and check a level. The difficulty is quite often we miss that opportunity to get the level checked. Certainly locally it needs to come from a gastroenterologist, and the problems are monitored in the community. And if they're monitored in the community but they can't check the level, we often miss our window to determine exactly what was happening.
And what do the metabolite levels tell us?
Well, the 6 TGN level is what I see as the good level, our active metabolites, which will be useful in causing some myelosuppression to the right degree at the right level. Our MMPs will be toxic to the liver at supratherapeutic doses, and when levels come back too high, we will need to take action. If the levels of both are low, then it may signify that there's non-adherence with drug.
Okay, so to make it clinically relevant, maybe we could illustrate it with a few cases if that's okay. Now let's say I'm the registrar doing your clinic and I've seen a variety of different patients and I've checked thiopurine metabolites. So let me give you a first case. A 28-year-old man with extensive colitis, so at last check colitis to mid-transverse. When I saw him, his symptoms were grumbling a bit, so he was opening his bowels 4 times a day with a bit of urgency. His azathioprine dose was 150 milligrams daily and his weight 80 kilograms, so it should be a reasonable dose. But when I got his levels back, his MMP and his 6 TGN were undetectable. So what do you think's going on there, and how should I handle that?
So when both levels are low, the first thing that comes to mind is non-adherence. Usually in non-adherence, the levels will be completely undetectable for both. And now, the way to approach that is generally requires some sensitivity, because presumably this gentleman's been at clinic, been assessed, had his levels checked, but hasn't volunteered the information that he's not been taking his drug. And it may be the case that he was taking it, or perhaps only missed it a few days long enough to have the levels come down. There may be another reason he's not taking his drug, and that needs to be explored with the patient and acted on. Regardless, it looks like he needs a dose increase or to restart his medication.
Okay, the next man then, so a 35-year-old man now, and he hasn't been doing well for a few months. His background is of Crohn's colitis, and he's also on azathioprine. So azathioprine 150 and his weight's 70 kilograms. So again, based on his weight, you might expect that to be a reasonable dose. He described a stool frequency of 5 times a day, and again with some urgency that he was finding quite difficult to manage. And he thought his azathioprine wasn't working. He was asking me, in fact, about a change of therapy. Now his metabolites came back. His 6 TGN was 200 and his MMP 230. So what do you think I should do with those?
So for this gentleman, I would usually look back at the TPMT. We should always have a TPMT before we start therapy. And if that was slightly high, it would give even more credence to increasing the dose. Regardless, we can increase the dose because his 6 TGN levels are low and his MMP levels are safe. I would recommend a dose increase, probably increasing if up to 200 milligrams if his TPMT was high, or halfway to 175 milligrams if his TPMT was normal, and asking our GP colleagues to monitor his blood test for the next 4 weeks on a weekly basis until we can be sure that his dose increase is safe, and then repeating his levels and seeing if we're hitting the appropriate level and to see if he can expect to develop a remission in the coming weeks.
Okay. Last one then. So this was a lady that was fine when I saw her in clinic. She's 49 and recently started on azathioprine and had been up titrating. But she was feeling quite well. But when I got her bloods back, her LFTs were deranged. So I managed to get her back to the day unit and we repeated her bloods and took the opportunity to get her thiopurine levels. So her 6 TGN was below the normal range, but her MMP was high. Now at the moment her azathioprine stopped, but I'm just wondering, what should I do with her azathioprine?
Well, this lady is clinically well, and there could be a debate of whether she requires it at all, but it's certainly not off the menu if we can be sure that her LFTs are increased because of the azathioprine and not for some other reason. Then there may be an opportunity to co-treat with allopurinol at low dose at 100 milligrams and reduce her azathioprine, as long as there's no contraindications to doing that.
So how does that work, co-prescribing allopurinol?
So allopurinol inhibits xanthine oxidase and allows for a shunting of the metabolism of thiopurines to allow for fewer MMP toxic metabolites and allow us to have a greater degree of thioguanine effective metabolites. The danger is, well, for one, an alert can come up in some GP systems that we're co-prescribing 2 medications which traditionally wouldn't be used together, but the GP needs to be clearly involved in this. We would generally reduce the dose of thiopurine to 25% to 33% of what the traditional dose would be, and for 6MP that often means a liquid preparation.
And are there limitations or problems that we need to be aware of when we're thinking about drug monitoring for thiopurines?
Yes, I think we need to be aware that idiosyncratic reactions occur regardless of our metabolite levels. And I think it's very important to counsel the patients clearly before they start that should they develop epigastric pain, which is new and severe, soon after starting, that they should immediately stop their drug. I also counsel people that if they develop any fever or infection, to stop their medication and have a blood test. And of course, there's increased risks of malignancies that the patients should be well informed of.
Moving on then to biologics. What drugs can we monitor and what are the potential benefits?
Well, at the moment, access is patchy throughout the UK, but we've been fortunate enough to have access to infliximab and adalimumab levels for the last 2.5 years. I'm told that we may have access to vedolizumab levels within a year, and ustekinumab, I'm not sure about their current situation with drug levels.
Now, I suspect the scenario that's most familiar is checking drug and antibody levels if a patient's not doing well clinically, so if they've lost response to the drug. Can you talk us through how to deal with that?
We're talking about reactive testing, so we've got a patient who's lost response, and what we're really looking for is there anything in a therapeutic drug monitoring result that's going to inform us of a decision that we can take which will help that patient's situation. So if our levels are no drug level and no antibody and she's on adalimumab, perhaps she's not taking it for one reason or another. If those levels are low but she has no antibodies, perhaps we have an opportunity to increase that drug. If she has low or absent levels and high titer antibodies, we may wish to consider changing to a different class of drug. We could switch within class, but then there could still be a risk of antibodies there. And if her levels are very high, trough levels, it would suggest there's good level of drug in her system, and we should perhaps think of changing to out of class to give her a better option that might fit for her.
Maybe I can give you some clinical examples, again just to illustrate some of these points. So there was a man that I saw in clinic recently with terminal ileal Crohn's disease. He'd been established on infliximab, but he was having recurrent abdominal pain with a bit of nausea and worryingly some vomiting. He was moving his bowels, his stool frequency was 3 times a day. So the IBD nurse had done his drug and antibody levels, which showed a low level of drug and was positive for anti-drug antibody and at a high titer. How would you approach that?
Okay, it looks like he has active disease, is on a drug that is not in his system, and although we can't be 100% sure what these antibody levels mean, I think it gives the clinician confidence to say that it is likely that he has anti-drug antibodies which are affecting his disease. The other possibility is he has a lot of mucosal burden of disease that is reducing his drug levels. But either way, it looks like a change in therapy is suitable for him. He should probably be counselled about surgical approaches, given that he's got terminal ileal disease and certainly needs more investigation there. But if he was to have a switch in therapy to a different class, if we were to decide to go with medical therapy, then that would be the way I would go.
So a different class being
potentially anti-endocrine therapy at the moment with vedolizumab.
What about this one then? A young lady, ileocecal Crohn's disease, and she's been well for years on infliximab. But lately, as her infliximab dose is due, she's starting to become a bit symptomatic. So her interval was empirically reduced to 6 weekly. When her drug and antibody levels were checked, she had a high infliximab level and no antibody. What's going on there? What would you do?
Okay, the question here is we probably want some empirical evidence that she does have disease activity there. It's somewhat a subjective finding to find a patient is having symptoms towards the end of their interval, and it's often useful to, in the first place, get a drug and antibody levels there to confirm that perhaps levels are reaching a low level before making that increase. So if they were available, it'd be worthwhile looking back at them. At the moment, it looks like she's still having some problems, yet we have made that change. She has active levels and she requires more investigation and perhaps a change in therapy.
And if you were going to make a change, what would be your strategy?
Well, again, with ileocecal disease, a surgical approach would be on the menu, but maybe something we want to discuss with the patient, and again, want to think about changing out of class.
Okay, last one. A 45-year-old man with Crohn's colitis this time, who'd been having some grumbling symptoms, despite fortnightly adalimumab. So his drug level was low, but he didn't have any detectable antibodies. What would you do with him?
Okay, this might be an opportunity to increase therapy, and our general protocol is to increase dosage rather than to reduce interval, and it's simply more convenient for the patient and usually more convenient for the hospital. And what we do is increase dosage for 3 months and then recheck levels to see where we are and decide on whether an increased dosage is going to be an ongoing plan or whether it's something we can revert to normal dosage or switch class if the patient's not very well.
Are there any other situations where drug monitoring can be useful?
Well, other than checking for adherence, and I should say that of the cases we picked up of non-adherence on adalimumab, they were unexpected cases. We did not think these patients weren't injecting, and when we inquired, it seemed they were not, and there were various reasons behind that. And it was certainly worthwhile for that reason alone to check levels. In acute severe colitis, there may be a role for this in the future, but the problem is the turnaround of the result is too slow to be useful in decision making.
Can you summarise then what you're doing in your own practice at the moment with therapeutic drug monitoring?
What we're doing, certainly with biological drug monitoring, is checking all comers at roughly the 12 to 14 week point. That's really after induction with infliximab, so that we can establish whether that patient should continue or not. And with up to 16% of patients showing results that require intervention at that stage, then we think that's worthwhile. If you have a cohort of patients who have never had drug and antibody level testing, then it can affect clinical decision making in up to 40% of these patients, and we expect low levels in positive antibodies in the low 20% range, so it's certainly worthwhile to check. We review all our biological patients on an annual basis at a virtual clinic where we go through all these cases, and drug and antibody levels are now an integral part of that.
Fantastic. Well, all I need to do really is thank you for a fantastic update in an important topic. And thank you for joining us for Digest This.